Good evening, everyone, and thank you for being here today at 7 p.m. after your working hours. And many of you joining here gives us this hope that we all are concerned about patient safety. And I'm very, very honored to be presenting the two ANEI Patient Safety Fellows today, yet another topic to be handled, that is hand of communication. Before I invite both of them, just give me a moment. Let me share and tell you a few things about Annie as well. Okay. So, friends, this learning sessions that you are uh, seeing, these are monthly learning sessions being brought by Annie Patient Safety Fellows. This is a program being run by Association of Nurse Executives India in partnership, in collaboration with Patient Safety Movement Foundation USA. And we have got three cohorts, which we started in 2021. The first cohort has already graduated. Second and third cohort, they are en route. The fellowship program is for 2 years. The first year, the Annie Fellows will be involved in learning and educating, and the second year, they are going to mentor the next cohort. Very soon, we will be announcing, inviting applications for cohort 4, and we hope to see some of you in the next cohort. So these learning sessions are being brought to you, as I informed earlier, ANEI Patient Safety Fellows. And these are based on topics from actionable evidence-based practices from Patient Safety Movement USA. I'm very sure that all of us are very busy with our day-to-day work. We may not get enough time to get into very important documents which talks about what works and what will not work, the issues and what are the current evidence that is available on the topic that is being discussed. So today's topic is about handoff communication, or call it shift handover communication. So the communication can be handed, sorry, the patient's details or the patient is being handed over multiple times in the hospital. So I am not going to step to the domain that our patient safety fellows are going to discuss. And I'll come to that in a moment. So I'm sure that you all are aware of the evidence-based practice definition that is right in front of you. It is expected from all of us professionals that whatever that we practice, it should be based on evidence. And I know that in India, we do not produce much evidence-based practice. There is research articles being published, but we do not have enough evidence-based practices. If at all it is existing, it is not known to many people. So we are hoping that we are bringing whatever is available through Patient Safety Movement Foundation, and our patients fellows are making an effort to read more what is on the topic and bring together what is in a very easy to understand format to talk about the topic that is being discussed. So it's a monthly event because in May we had Anicon, which is our flagship event, which was held at Chennai. We will have two sessions in June. So this is the uh, handoffs communication is from the month of May. Then we will have June, and you can see that all the topics are already decided and assigned to various, ANEI Patient Safety Fellows. So, evidence-based practice in nursing involves holistic quality care, most up-to-date research and knowledge rather than traditional methods, advice from colleagues or personal beliefs. Believe me, friends, that in my company, as I do the training, I know I come across many hospitals which are even accredited, but they are out of date when it comes to evidence-based practices, whether it is the guidelines or around CLAPS or WAP. So it is very important that we should be well read and up to date. And this is a humble effort from Association of Nurse Executives India to bring in the latest through our patient safety fellows. So, friends, we are very, very happy to inform that the Anicon, which was held at Chennai on 25th May, was a stupendous, successful show of leadership. Any many nurse leaders, they came to Chennai, and we had over 500 participants. It was a huge success, and it's already decided that next year Anicon will be in Kerala, in Kochi. Decided. May I ask everyone to mute themselves, please? Hello, Vijaya, please make sure that they are muted. So during the Anicon, we had various competitions, whether it is elocution, quality improvement projects, or posters, or the research. So all of them were conducted, and the winners were already announced. And we had given 5 awards to outstanding nurses. And this year, we are very honored that we could also award 2 veterans who are not nurses. Dr. K.M. Cherian, who is the father of, cardiac surgery, and Dr. Girdhar Gyani from AHPI. They both were given Lifetime Achievement Award, along with Madam Abadhi Gopal from Bengal. Many of you must be knowing her. She was also given the Lifetime Achievement Award from nursing. So Association of Nurse Executives India gets stronger with more members. So it is also my endeavor now, before I invite my, presenters today to take over from me, that join us, make us more stronger, make our voice heard at the quarters that is required, more in number, and you will be heard at higher authorities, and we can advocate for nurses. So, central line associated bloodstream infection is going to be dealt with Lata and Ishita on 27th June. But before that, let me go back to my earlier slide and invite. Oh, where are my photos? Seems to be missing in action. No worries. I'm going to invite them directly without wasting any time. May I invite Ms. Rafia Islam, the ANEI Patient Safety Fellow from 2022, and Dr. Rosaline from 2021. May I ask you to put on your video and audio, please? Thank you, Rafia and Dr. Roslin. Thank you. So they are our patient safety fellows who are going to walk you through the handoff communication. So I'm going to stay muted. I'll go off video, Roslin and Rafia, and it is over to you to handle today's session. I'll pitch in if I have something to share. And to all the people present here, please remember, to end of the session, we will be sharing a link for feedback form. If you fill it up, you will get an e-certificate for this particular program. So stay with us and listen to us and take away something that you can use starting from now. This is what we are trying to showcase, the sessions that we are trying to hold. So thank you for being here. So we already have 70 people. Oh, thank you very much. And that's very, very motivating to see so many people in the session today. So over to Dr. Rosalie and Rafia.
Thank you, ma'am, for that warm words of welcome. Good evening to all who have gathered here. Once again, I want to thank you all for joining us. Today, myself and Rafia will be talking to you about handoff communication, which is not something which is new to you. Each of us do a lot of handing over and taking over in the process of our everyday, day-to-day life. And especially as nurses, all of us have been taught about the value of communication. So this is one type of communication which we use in our everyday handing over of patients from the nurse who has taken care and to the nurse who gives the care in the next shift. So I want to share an important word saying that before we start off what it is all about, it is sharing accountability of knowing and safeguarding the patient. So we are all here this evening connected that our patients are our customers and we give value and importance to them. So if we miss out on any of the information, we are not accountable. So to make ourselves more accountable today, Rafia will be taking us through what is handoff communication, the various methods, what are the barriers. So I want the participants to actively share your inputs. If we missed out or if you have any doubts, kindly use the chat box. So we will get back to you. Keep yourself muted throughout. So we will have a time of discussion at the end of the presentation. So over to Rafia to share the information.
Thank you so much, ma'am. A very warm good evening to everyone. It is an immense pleasure for me to present the topic hands-off communication on this esteemed platform before the distinguished audience. I am honored to discuss about the topic hands-off communication in nursing. I extend my sincere gratitude to the organizer, my mentor, and the Thangam Gomez ma'am for providing us the opportunity to discuss about the topic. So, patient safety is the cornerstone of quality healthcare. It is every healthcare provider responsibility is that to provide the safe and effective care to the patients. And hands-off are the key of making sure that each participant receives constantly high quality care from provider to provider, from one unit to the another unit, and one shift to another shift. All of you know that, already aware about that, what are the things we need to include in hands-off communication. Then also, one more time, I am telling that when we will give the hands-off communications, that should be include up-to-date information about regarding patients, treatment, service, what are the condition of the patient, any recent or anticipated changes are there. All these things we need to include in the hands-off communication. But the question is that why we are telling about hands-off communication? What is the evidence of that hands-off communication? Why it is so much important for us? So here is the evidence. If we will see that patients' hands-off are the most frequent and riskiest procedure in a hospital. And evidence shows that 60% of nurses reported at least one incident communication failure during hands-off. Even also, studies shows that 23% of medical error in the hospital due to the hands-off communication. And also studies shows that there near about 1,700 patients' death occurred due to failure of hands-off communication, and which is cost near about 1.7 billion. It's not just a small amount because of a simple hands-off communication failure. Now, why this is so much critical or so much important for us? Now, I would like to request Dr. Roslyn ma'am to enlighten this point.
Thank you, Rafia. So here we see that missing on an information. The previous slide, she had shown us the statistics, which is again at USA, and we do not have much studies which has happened in India, where this is an important information which needs to be, without any break, being communicated to the next nurse who's going to take over. Can you click on to the thing, Rafia? Yeah, the first one, we are all here to ensure that our patients are safe when they come into any hospital setup. It can be an outpatient department or it can be an emergency department. From there, the patient could have been transferred to the CCU, or it can be straight to the theater and then they come into the ICU. So we make sure at every point of contact, we give the right information about the patient to the next nurse so that no bit of information is missed out in the process of care. So this helps us to know that there is a continuity of care which is really taking place, whereby by giving the correct information and all that has to be done for the patient, we minimize errors. How does errors really happen? By missing out on certain informations which has to be passed on to the incoming nurse who's going to take care of the patient. She does not know what has happened overnight. So if we do not tell the information to her, she misses on that during her time of care for the patient. So this also enhances the communication among healthcare team members. How does it enhance among the team members? Probably the doctor would have told the nurse to inform once the result comes in, and he would have gone into the theater. Or it could be an alarming investigation result which has to be notified to the physician, after which a decision could be taken. Or there could be a delay in the procedure, and this is the reason why we need to pass on the information. Sometimes it could be the physiotherapist who wants to make the patient to be comfortable, after which he would like to continue the procedure. So team members play a pivotal role in caring for the patient, and the center of the pivot is a nurse who needs to communicate to her team members. Then it also plays an important role where we engage ourselves with our family members. So we are, as nurses, we need to pass on certain information, and it is between the incoming nurse and the outgoing nurse who's going to really take care of the patient. The information has to be the same. We would have said by 7 p.m., we will be allowing you to see the patient. You will be allowed to talk with the patient. So this has to be handed over to the next nurse, and she has to ensure at 7 o'clock, if the patient is still asleep or a medication is given or a procedure is going on, she would connect to her relative and say that we will be delayed in another half an hour. I will call you in to see the patient. So this gives a close networking between the patient and the family members. And we all know that documentation is something very important. It is not only oral handing over which takes place. Every information which we are passing on to the incoming nurse is all documented in the chart. So it is very much evident. Even if some information is missed out, she is able to look into the chart and verify all the timing, and then she continues the care. So handing over is very critical in taking care of our patients at the hospital. Next slide, please. Yeah, when we consider certain questions where our failures really happen. So I'm sure all of you with your experience, you can add up points to these questions which I have put up here, where all failures could happen. In my experience, what I have seen is the nurse who's coming in is not ready to take over from the nurse who's ready to hand over to her. So there are two people who are communicating, the nurse who is completing her shift and the other nurse who's coming in to receive the information. So during this time where the incoming nurse wants to hand over these information to her, what really happens, there could be a disturbance happening at the bedside, or there could be a shifting of a patient, or there could be an emergency, there could be a code blue happening there. So during this period of time, there could be a distraction which is happening over that particular place, which causes the nurse to get distracted from receiving whatever information she gets. So in all these questions, if you see, how can we provide an opportunity for improvement? So as an in charge, when the nurse who is there as an in charge looks at a situation, we need to create an environment where we make sure that the handing over and taking over process is not in a disturbing environment. We need to make sure no disturbance happens, and somebody else will have to take up the information, the emergencies over there, so that we will be able to pass on the information. And when we are doing it, we need to involve the patient. And when the nurse is listening to all what the nurse tells, she has to go near the patient, communicate, look into the monitors, hold on to the patient, and she needs to move around to make sure things are happening. And this sort of a thing really makes the person to be comfortable. And if at all there is some sort of a disturbance happening, we need to say, are you clear with what I'm saying? Do you want me to repeat back? Looking at the nurse who has come in, if the information is not readily accepted by her, we need to make it very clear. And also we need to make sure that they look into the chart and get all the informations, whatever we have told is also documented. By doing so, I'm sure we will be able to take the nurse through in all the aspects of patient care. Rafia, would you like to add something more to this?
No, yes, ma'am. Or definitely, whenever we will see the failure of hands-off communication, definitely we have to consider all this point, all this question. We have to improve ourselves. Next is that key component of hands-off communication. We all are aware about the key components of hands-off communication. Then also I will one by one I will explain. First is whenever we will do the hands-off communication, then we have to tell the brief history about the patients. So brief history means you have to tell about the patient's name, patient's age, patient's diagnosis, patient's MRD number, about the patient details, everything you have to include. Then about the physical assessment. So as a nurse, whenever we are receiving any patient, we will do the head to foot physical examination. So before hands-off communication, we have to complete the physical assessment, and then only we have to provide we have to give the handover to the another staff. So during physical examination, particularly, we have to mention that is there any injuries? Just for example, if a patient is having a bed sore, so any skin integrity problem is there, so we have to mention that one. Or if the patient is having any like any abnormal respiratory rate or abnormal vitals are there, that all these things we have to mention here during the, particularly we have to mention in a hands-off communication. Then clinical data of the patients. So clinical data of the patients means what is the present problem, what chief complaint of the patients, that we have to include. What the treatment process is going on, that all these things we have to include in that. Then pending test result. So whenever we are receiving our patients or doctors are prescribing lots of investigations, or sometimes we are sending the like blood investigations, X-ray, CT scan, MRI, we are sending to the lab for blood investigation or urine examinations. So sometimes we are getting the result, or sometimes we are not receiving the result. But if you are not receiving the result, or is there any abnormality in the result, so that all these things we have to, as a nurse, we have to mention during our hands-off communication. Then ongoing treatment process. Is there any ongoing treatment is prescribed for the patients, or any patient will go, just for example, patient will go for physiotherapy, or patient is having investigations, or patient need to go for counseling. So that all the things we have to particularly mention during the hands-off communications. Then about the medications. Most of the error we can see during the medications because of hands-off communications. So medication, we have to explain about the patients, whatever the patients are getting, or is there any home medicines patients are continuing, or what is the dose of the medications, what is the when the patient will get the medications, that all these things we have to include in the hands-off communication. Overall, all this continuity of the care we have to explain during hands-off communications. Next, we'll move into the causes of ineffective handover. I hope all of you will agree with me all these causes on ineffective handover. First is that communication breakdown. So it is a foremost problem for during the hands-off communications. Like if a patient is prescribed for any medications and all, it is not communicated. Or particularly like one surgery happened to the patient, and patient should not be, patient is restricted, patient should not go out, or we have to every day we have to check the patient's drainage. All these things during handover time we have to mention. Then next is that culture and the language. So it is also one of the causes of ineffective handover. Here in India, we can see from one state to the another state, people are coming for the treatment purpose. So sometimes the patients are not able to explain what is their problem because of language problem, because of the culture problem, and what is the treatment process is going on. If we are not communicating properly, what medication they need to take, what diet they need to take, what are the restriction is, if we are not explaining properly because of the language problem, because of the cultural problem, so there will be the patient will be at the end, patient will be the affected. Then lack of standardizations too. We know here all the tertiary care hospital, all the corporate hospital, most of them are following the standardizations too. But my question is about, what about the government institution? There also patients are coming. They are also want to get the care, quality care. Now also in a government hospitals, many government hospitals, they are not following any hands-off communication standardization tool. Now also they are following the like writing or register method, or there is a no protocol for the hands-off communications. Then inadequate time allocation. Yes, this is the another problem of ineffective hands-off communication. If in an institute, we know we are in India, there is a shortage of nurses going on, and nurse patient ratio is not proper. So whenever one nurse is assigned with 6-7 patients, so during handover time they are rushing, they are make it very not make it very clear or concise. They want to finish off their hands off, they somehow they will finish off, they follow the shortcut, and they will give an incomplete handover to of patients. They will not clearly explain, or they will rush that, they will take the shortcut form. So there we can see the causes of ineffective handover. Then incomplete communication. Always as a human being, always we want shortcut. So during patients handover time also we want shortcut. How come, how fast we can finish all the 6 patients handover and I can go off home. So these are the another causes of ineffective handover. Then interruption and distraction. This is a very, very important. Whenever hands-off communication is going on, or one staff, one shift to the another shift, there most of the time we observe that one shift to the another shift, the nurses are giving handover. What they are starting the handover, and meanwhile one patient came and telling that, please come, my patients wants to go to the toilet, and for that we need an assistant. So the nurse, what nurse will do, they stop the handover and they will go to assist the patient. Then when she will return back, meanwhile she will forget about that, what is the important thing she wants to mention, or she wants to give a handover. And then non-compliance handover protocol. So this is also another causes of ineffective handover. Here I would like to request Rosalyn ma'am, if you want to add something on this point, the causes of ineffective handover.
So especially as in charges, it is very important that we maintain a good environment, a conducive environment when the handing over and taking over is taking place. When you said inadequate time allocation, during my study, it was found that the overlapping of shift, say for example, 2 o'clock, the shift is getting over, the incoming nurse steps in at 2 o'clock, she checks whether the articles are kept, is ready, and then she comes to the nurse, and during the process of the handing over, there is something happening there and there is a delay. So the nurse who wants to leave after her shift, it gets delayed to 2:45. She's hungry, or some patient comes in. So there was a lot of distractions, and it was decided that there will be an overlapping. By 1:30, the shift will commence, so that by 1:30, the incoming nurse comes in, checks her articles, and then the handing over takes place. So around 2:15, the nurse is able to leave. The same thing was happening during the night duty also. So these sort of little modifications in the time factor made the incoming nurse to take over in a relaxed manner, and the person who wants to complete her shift and leave, maybe the bus is leaving or she's in a hurry for some other engagement, all this made sure that the handing over took place in a very cordial way. Yeah, the next slide, please.
So here we can see that these are the causes of ineffective handover. Now we will see what are the strategy to improve the effective communications. So here I would like to request Rosaline ma'am to.
So here in the strategies part of it, the first thing is introducing yourself. So as the incoming nurse has come in and I am there with the patient from morning till afternoon and I want to hand over. So as we are doing it, there's something happening between both the nurses at the bedside with the chart, and we are looking around and we miss on the patient who's there right in front of us. So it is very important that at that moment, just go around the patient, just hold on to his hand and say, I am finishing my duty and I'm here to hand over, and Miss So-and-so has come in to take care of you. And during this process, call out the patient by name, and the person who's taking over, she just looks into the ID band, identify the patient by name and the UHID number. So the interaction is taking place between the patient and both the nurses, but at the same time, you are involving the patient in your care process. And he is also comfortable to know that he is being introduced there. The second thing is he's aware that who's going to take care of him the next 7 to 8 hours of the shift timing. So introduction, I have found that is very cordial, and it is always, the patient feels very comfortable when we do that introduction. And the second thing is standardized method. There are a lot of standardized methods of care which is taking place. Each hospital has one, and we will be seeing shortly what are the different methods. Whatever may be the method, the patient is the focus. So when the patient is the focus, all information, it has to be like, a story from the beginning. Whatever the night nurse would have handed over to you, or the theater nurse would have recited an incident which has happened in the theater to you, and then you are handing over important information related to the patient care. We need to incorporate whichever may be the method which is comfortable to you to use at your hospital. Ensure that every information is being covered. That is very important. And as I said earlier, give adequate time. Do not do it in a very fast-paced manner, because you are in a hurry to leave, you have an engagement later, or the incoming nurse getting engaged with some other work with somebody, and then halfway through listening to certain things, and she says, it's okay, you can leave, I will take care of all this. Everything you have recorded, no? Anyway, I'll go through the chart. And after the person leaves, searching for information can miss out on the time of care which has to be given for the patient. And all the informations, when it is documented and you have a format, and using that format, every information when we are writing down and handing over, we will not miss out on any of the informations. And even if the nurse fails to miss on listening to certain things, it is documented. So accurate informations. Not saying that the sodium level was low, so doctor gave, I'm not sure about the value, I'll let you know. So that sort of a thing should not be there. Say what was the value and what was done and what has to be done during the shift in monitoring that patient. So this is very important. So as an administrator, very frequently in your setup, we need to have regular audits happening about the documentation process, how the handing over takes place, and listen to the nurses. Between maybe two novice nurses, they have modern things. They would have got everything in their mobile, and quickly they would be handing over, and they will say, I will send all this information to you. No, when such a thing is happening, you need to listen to how the things are happening, and we need to do a correction. It is very, very important. And prevent barriers. There could be a lot of barriers related to the patient, related to the language, related to, you may not be that comfortable when somebody is telling you a long story. You may not like it. You want everything crisp and clear, and you want to be very fast, and the other person drags the information long. So whatever may be the barrier which is present at that moment, whatever may be the situation, ensure that all pertinent information related to the patient has been delivered to the other person. So we will see some of the barriers which which happens during the handoff communication. Rafia, would you like to take it from there?
Yes, sure, ma'am. So every healthcare setting, they are having their own hurdles to implementing the hands-off communication. That some could be the internal, some could be the external. But here we can see there are 5 factors are there, which are the barrier of effective hands-off. So first is that standardization process. So poor organization support. If we have to if the hands-off communication, any protocol or anything we want to implement, so we need a organizational support. It is each and every member, not only the only nurses will follow, the other people will not follow. You have all the team members should be, it is for the doctors, it is for the nurses, it is for the housekeeping, it is for the technicians, it is for the dietitian. Everybody should follow that. If they are not following, so there will be the ineffective hands off. Then lack of leadership. As a leader, here are the lots of in charges are there, NS are there, CNOs are there. So all have to train their nurses about the effective hands-off procedure. Then failure to adapt. Sometimes here the things are coming like that. I am a senior staff, why I will follow, why I will train them. So we are not going to adapt a new thing, because again we need to learn. So these are the failure to adapt are there. Then destruction. So destruction during hands of time, there should not be any noise, any disturbance. We should not distract it. So most of the time when I am going to the hospital, the handover going to the nursing station. Why to the nursing station? We should go to the bedside. In front of the patients, one nurse will give handover to the another nurse. Then lack of time. As we are busy, we are in a pressure, we are in a hurry, so we are not giving enough time, not explaining properly what are the things we have to do. We are not explaining, like as a patient is having hyponatremia and we have to provide the extra salt to the patient. Patient extra salt is keeping to the bedside, but we are not explaining to the family member or the other staff, this extra shawl you have to add. Again, the another staff is coming, or again the in charges are coming for a round. That time they are observing that morning extra salt in a packet, it is giving to the bedside only. It is not given. So how the sodium level will improve? Then many tasks in a one time. So we are dealing as a nurse, we are dealing with a different department, like all the departments in a hospital, admission, discharge, nurses, nursing department, OT, lab, all the departments we are handling. So many tasks, if in a one time, if we want to do, so there will be the hands-off communication error will be there. Then prolonged working hour. If we are working so much time, sometimes some hospital, because of shortage of time, they are giving the double duty. So too much, like from morning 8 o'clock I came for duty and I am going home to the night 8 p.m. So this is of 12 hours we are standing and we are assigning with the 6 or 7 patient, 8 patient, 9 patients. So it is very difficult. So we will miss out important thing to communicate. Then workload. Definitely workload is also one important thing. If we are handling this many patients, this many department we are handling, we will miss out that. These are the barrier of effective hands-off. Then next, like negligence. So negligence is the another barrier of the hands-off communication. We know that, as Madam Rosalyn ma'am told, that if the patient is having like hyponatremia or any blood values is less, if we are telling it is low, no, we have to explain in a number that your this patient this patient's like sodium level is this much low. So particularly you have to mention. Or patient is having like a medications, and patient, you give the medication to the patient, but you are not documented. What will happen? Again, next if the staff will come, they will see the signature is not there, again they will give the medication. So it is because of negligence. If drug overdose will be there, or if a patient is having any allergy to any medication, So particularly during hands-off time, we have to explain that, okay, this patient is having allergy with this antibiotic. So next person, by seeing that, they should not forget or they should not miss out. So otherwise, it will be a allergic reaction for the patients. Then error in documentation. Like whatever we are doing, we have to document it. First, we have to do the procedure. Then we have to document. If we are doing mistake in the documentation, definitely it is going to a problem. Then misinterpretation. Sometimes we are misinterpreting the result. Whenever we have give handover, definitely we have to tell that the sender need to tell the receiver that, please, what do you understand what I tell? If you are not understanding, please ask me question. Otherwise, receiver will tell in a one point of view and sender will tell in a one point of view and receiver will receive in another point. So here we have to clearly explain that these are the things you have to do. You have to follow that. Then another factor is that patients overload or deterioration in the patient condition. Sometimes we are giving handover and patient is graduated. Code blue is there, rushing off. So we are going to care that code blue patients. So we are forgetting about the hands-off. So these are the barriers of effective hands-off. I hope Rosalind ma'am will agree with me.
Exactly. Whatever you said, I agree upon. These are practically happening in an everyday handing over. The situation really has to be manned by each one of us when we are taking over from the client.
I will request Tangam ma'am, if in your experience, if you want to share any stories with us, so it will be great help.
So I will keep the stories to the end.
And
Because I'm also looking at the time. So may you both complete and then I will come in. I have lots of stories about
Okay, ma'am.
not one,
Okay.
many. Okay.
Okay, ma'am. I will looking for. Okay, next. What are the tips of hands-off communications? So here are the tips of hands-off communications. First is that provide hands-off in a same order every time. To whomever we will give handover. If it is a one provider to the another provider, it is from one unit to the another unit, we have to keep in a same order. If we are following any checklist for hands-off procedure, so it will be in a same order. We will not miss out any points. Then use the verbal communication. Definitely, we have to use the verbal communication and we have to explain in a detail, concisely, clearly, whatever the instruction we want to give in a hands-off. Then allow two-way exchange. Already I explained that whatever handover we will give, we have to ask them, do you understand? Repeatedly, we have to ask them and we have to ask them, please tell me what you understand. Then only we can, as a sender or giving, as a nurse, we can understand that is there any point missed out. Then limit of destruction. So during hands-off time, we have to give a handover like that way. So that time nobody will disturb us. Or like most of the time we are saying we have nurses started the handover and doctor's round came. So they stop it and they run for the doctor's round. So there will be the distraction. Or patients came and patient is telling, oh, sister, come for my patient's IV fluid is not going out. Please help me. So patient, the nurse will run. So these are the things we have to keep in mind. Then allow the others overhear the information. Here, allow the other means here particularly I want to mention about the patient and patient's family member. Whenever we will give a handover or patient is having any investigations or tomorrow morning patient is having USG or patient is having any surgery, while I will give an evening shift staff want to give a handover to the night shift staff, then they clearly explain that, okay, the patient will be empty stomach after or patient will be in a NPO at from the 12 a.m. So if we clearly explain that, maybe near to the patient's family member will be there. Or patient can hear that. So they can understand that, okay, from 12 o'clock, I can't drink anything, I can't eat anything. or tomorrow morning, because of the USG, I will not eat anything. So these are the things we have to engage the family member. So then family member will get a trust relationship. Okay, my beloved one is in a, they are taking care of nicely my beloved one. Then complete the patient assessment prior to hands off. So many times we have seen that some halfway completed the assessment, and then they nurses are starting to hand over to the another shift patient, because it is already nighttime, evening shift finished, night shift started, and it is already 8:30, 9 o'clock. I have to, I can't stay further. I have to go back home. So next shift duty will do the assessment. All these things we have to keep in mind. Then includes 5P. We never forget about this 5P. That is the patient's name, patient's name, problem list, plan of care, and purposes. So all these things we have to explain include during the hands-off communications. Now we will see the types of tool available for hands-off communications. So I hope all of you use in your institution different types of tool. So here is that ISBAR, sign out, hands off, then IPAS is there, then SHARP is there. So in your I will request the audience, if you are using any of hands off tool in your institution other than this, you can put it in a chat box. So ISBAR I stand for introduction. So introduction we have to, whenever we will start the hands of communication or we want to give handover, first you have to introduce yourself, that who I am and to whom I am giving the handover and whose handover I am giving. About the details about the patient, you have to explain patient name, age, HUID number, all these things, diagnosis, everything you have to explain in a details. Then we have to tell the situation. Say what is the patient current situation, that we need to explain. That when the patient came, what is the chief complaint of the patients, why patient here, that all these things we have to explain. Then B for background. How long patient is having a disease? Is there any past history of that? Just for example, if a patient is a diabetic patient or hypertensive patient, so how long the patient is a diabetic patient or how long patient is a hypertensive patient? Patient is taking, what are the medications patients are having? Are the patients are taking the diabetic diet or they are in a regular follow-up? That all these things, or how many times patient is admitted in a hospital. So all these things we have to keep it include in a background. Then assessment. We have to do the assessment and we have to include there is any important thing. Then R for repeat back or recommendations. So during handover time, we ask that please repeat back what are you understand, or is there any recommendation or further you have to do, or we can ask that please do you are having any request you want to know from me. All these things we can follow through this tool during hands-off communication. Next, another tool is that IPAS tool, and this I will request Roslyn ma'am, because she she had done the quality improvement project for patient safety, and she used this IPAS tool. I think she will explain more in regarding IPAS tool in a detail.
Yeah. IPAS was the quality improvement project I had taken for my fellowship program. And this IPAS acronym stands for, I stands for illness severity, patient summary, action list, situation awareness, and contingency plan, which the outgoing nurse takes up this particular area. And the synthesis by the receiver is the summary, which is given by the incoming nurse. So I will just scroll through my tool, and because we are running short of time, I can share it with you later. So here in the I part of it, 3 components were taken up. That is, I have already told you about how we introduce ourselves, and I will say, good afternoon. I am the nurse who's going to take care of you this afternoon. How are you, Mr. Kannan? How are you doing? And then gradually look into the ID band and just assess the patient around, and identifying the patient by name, by checking on the UHID number. Lot of errors was prevented due to that. And in the process of the handing over, it also has the note about whether the patient's condition is stable, anything to be done, certain things which you have to watch over this particular patient because his respiratory status is fluctuating. When you say that, the incoming nurse becomes alert that she needs to note on the respiratory status of the patient. And the second part of it is the P, which comes for the patient summary. In this patient summary, it could be the past diagnosis, the problem with which the patient has come in, what are his comorbidities, what are the medications which he has taken. So here also in this particular part, we found that some medications which the patient was taking for a long time, his thyroid tablets or his type of insulin which he was taking, he came in, his sugar was high, and they started with a insulin therapy, and then it was ongoing. But what was he really using? It was missed out for 2 days. Later, when the diabetologist came in and when they pulled out the chart, they found out that that information was missing. So the initial part of the patient summary is something which has to be always briefed out. In case the previous night the nurse has taken care and she's coming back again on shift, she would be knowing that, so we can make it little more briefer there if she knows the patient. If both of them are new to each other, it is very important that we share that information. And then the hospital course of care, which is going to happen. So quick assessment moving around the patient, checking about his diagnostic studies. So as the nurse hands over, the incoming nurse just flips through the chart to see whether the investigation results are all in, whether the documentation is being done. And she says this particular consultant will be coming in today by 3 p.m. So he wanted all these things to be kept ready. So as the incoming nurse is listening to all what the nurse is handing over to her, she flips through the chart and checks whether all the informations are in. Then the action part of it, what are some of the things which has to be collected? It could be a pending result, or a consultant has to be informed when the patient is ready, or it could be a procedure which is scheduled in the afternoon and the patient is already nil per oral, or the diet has to be ordered after 4 hours after the procedure. So that would be at 6 p.m. He has to be started on oral fluids. So I haven't informed the dietitian. So please make sure that you order for clear fluids at 6 p.m. So these sort of information has to be informed so that there is no delay in the patient care. And medications, especially when the patient is being shifted from the theater, it could not be during the timing. The antibiotic or any type of medicine would have been started in the theater, and during the routine time, the medication time wouldn't fall. So in that case, you have to say the next dose will fall at 3:30. So if you are planning to adjust it and bring it back to normal, how are you going to do it? So that sort of a communication has to be made clear so that medications all would come together. So these things will also be handed over by the outgoing nurse. Next slide, please. So the last one which the nurse hands over is the ongoing assessment. What is the ventilator settings which is there? What are the antibiotics he's getting? What are the problems in the next 24 hours you can expect, or even within the next shift? What are some of the alerts which you have to be there? And allergies. Sometimes these allergies or, blood cross-matching is going on. There should be a blood transfusion which has to be done. These informations have to be really informed to the person. Next slide, Rafia.
Yes, sir.
No, you went into the, yeah. So okay. So the last part of it is the synthesis. Synthesis is the summary. That is, the incoming nurse now summarizes whatever she has received, and she clarifies all her doubts, and she repeats back, or she will, whatever she wants to tell, she really repeats back and clarifies things from the incoming nurse who has told the information. So this is how the study had gone in. So the initial part of it, we did an assessment. What is the type of tool they were using in? Then we taught the set of ICU nurses. It was piloted in a single ICU and it was not spread throughout the hospital. So in the ICU, we started to teach the nurses and they started to practice, and we made sure that we were available during the shift when they were handing over, so that we taught them how it can be done. And slowly within 6 weeks, they become very comfortable, and now they have started to implement this particular tool and they find it very easy to follow the instruction, and the errors have also come down. Next tool, Rafia.
So yes, ma'am. So there are the another tools are available there. That is the SARC. Here we can see that SARC is for situations. Already we explained that thing. We just go to H stand for history and R stand for recommendations and the O for question. So here we are including only in this tool extra is there the questions. Then sign out, another tool is there, that is that S stand for sick or DNR and I stand for identifying the data of the patient, about the general hospital course in there, when the patients came into the hospital, what are the treatment was done, then new event of the day, what is the chief complaint now, what is the present complaint now, that will be included here. Then we will include here overall, O stand for overall health status, then upcoming possibilities and the with the rationale, and T for task of complete with the plan and the rationale. Then another tool is there, that is the PACE. That PACE, P stand for patient, all these things about the patient. If stand for assessment or action. What are the assessment we will do, that will be included during the hands-on communication. Then continue to, is there any changes or is there any medication changes or investigation changes, that all these things will be included here, and the evaluation will be there. Next is hands off. So H stand for hospital location, A for allergy, or is there any allergic reaction is there, N for name of the patient, detail is the D for DNR, is there any DNR is there or not, O for ongoing surgical problem, is there any surgical issues are there, F for facts about current hospitalization, and F for follow-up. So these are the tools are available in available there, so we can follow that. Then last is that this is not a tool, it is a check back method. Definitely whenever we will do the hands off, then we have to check it back, whatever the sender will tell, we have to request them, please call it out, check back, repeat back. So these are the another two method for hands off communications. So if we are not provide the accurate care or accurate handover, it is not timely, it is given to the patient, if it is a incomplete, if it is a miss, so there will be the impertinent hands of communication, and at the end which is cause the patient's harm. Next is how to use the hands off effectively. Already previous slides we explained that we have to transfer the responsibility and accountability, clarity of the information, appropriate communication for information, acknowledgement is required by the nurse receiver, and opportunity to ask and review. Definitely we have to, hands off means we have to repeat it back. Then solution to improve the hands off. So as a administrator or as a leader, we have to find out which hands-off tool we are going to use. What are the checklist will be there? How we can improve that, all these things as an administrator to improve the hands-off communication. Then we have to make the, we have to develop the standardized SOP for hands-off communications. And we have to adapt the structure too, if it is a ISBAR or it is a IPAS, or the another for which is applicable for your institution. That all these things we need to help to improve the hands-off communication. Then involving the multidisciplinary team. As I told, nurses are not only the responsible for the patient. Each and every healthcare providers in an institution, they are responsible for the hands-off communications. So everybody should be trained on that. All the level from housekeeping to the top level, everybody should be trained about the hands-off communication. Then as a administrator or as a leader, definitely we have to do the regular audit. Then only we can find out where the gap, where is the loophole is there, that we will able to find out. Then we have to get the feedback from the staff where they are facing the problem. Along with the feedback also, we have to get the suggestions. Please provide the suggestions so we can improve it. Then an organizational culture. Build a culture of trust, that where the all the team member will feel confident during the hands-off communication. Then at the end, I will conclude my topic with that we are handling with the patient as a human being. We are not handling with handling the machines. So we have to be very, very careful during hands-off time. So achieving a balanced, safe, effective communication is the goal we are still trying to achieve. So these are the references I used for this presentation. So thank you to all. Now I will finish. I finished my presentation. Thank you, Roslyn ma'am. Over to Tangam.
Thank you, Jyoti, for that. In the chat box, she has said that it should be in the common language. It is very good. So actually, sometimes, we talk in the local language, and between two nurses, if language is a barrier, so well appreciated. It should be in the common language, and whatever you hand over, it should be in the common language, English, and it should be written. That is very important. Over to ma'am for add-up.
Thank you. Thank you very much, Dr. Rosaline and Rafia. Well dealt with. It actually can go on for, a couple of hours, and it can be for a workshop with role play, etc. So we have only kind of, touched upon the overarching domain of, handover communication. And please remember, across the world, the communication remains the top 3 reasons for all sentinel events. So it can never be, undermined that, how we communicate, when we communicate, whether we communicate completely or not. All these things are very, very important. So now I promise I'll tell a story. I'm going to tell a story very quickly because Dr. Roslyn reminded me that. So this happened long time ago when I was in Fortis. So we had introduced a shift handover and, the tools, etc. And we used to audit. I used to go to different Fortis hospitals, and I will actually speak to patients. So one of the tip that I would like to give to all of you is that whenever you introduce tools, whether it is this bar, iPass or readback or whatever, please try to audit and speak to the patient. Teach back, these are, everybody knows these tools, but it's very important to ask the patient. So I had gone to this one hospital, and the audit was going very well. The CNO was also very happy because all the patients are giving very good feedback about the nurses, So she's very happy. So we went finally to one of the patient's room. There I randomly I select patient and I went inside. So she was a new mother. I mean, she had just delivered, and she knew English and Hindi very well. So I kind of asked her, how are you and how are the nursing services? So she said, this place is so good. I don't have to even ring the bell. They're always here. That means hourly rounding was happening because that was one of the things we had introduced. That means she said almost every 45 minutes, 1 hour, somebody is here. I don't even have to ring the bell. So I said, okay. So during shift handover, do both nurses, they come here? So she said, yeah, they always come here. I said, do they introduce themselves? She says, yes, they always tell, I'm going, Rafia is coming on evening shift, they always do that. I said, do they involve you in your, handover? Do they involve you? Then she said, oh, that is something, I would love to, but they speak in their own language, so I don't know what they speak. Finished my audit, right? So Suddenly everybody became, all the colors went off, and it's like, see, what I'm trying to tell here is that it's very easy to plan things and put checklist and do a lot of things, but if you don't go monitor and measure, it will not be happening. That's the thing. And I'm very sure that Dr. Roslyn, when she went closer to the shift handover, she realized all the gaps which were there. And another thing I would like to share is that there are many tools out there. So you need to find out what tool will work with our nurses. This is very important. I feel ISBAR is not a tool for shift handover. ISBAR is very good for communication, for clinical purposes, especially informing doctors. So if nurses are trained to do one tool for one particular purpose, probably they will follow it to the T, and you can make your patient care more safer. So out of all the tools that I have gone through so far, I have found iPass seems to be far more practical and more easily understood by nurses. And I think Dr. Roslyn agrees with that. This is one of the tools, and you can always tweak what needs to go inside those, iPass tool, what the nurses need to tell. And one of the things, me as a nurse, when I was working in critical care, we didn't have all these tools. We only had patient file. We will stand right in front of the patient and we will tell, okay, Mr. Sharma, I am leaving and Rafia is here in the afternoon. We are going to talk about what's going to happen in the next shift. Please listen, and if you have any questions, please butt in. This is when conscious patients are able to participate in the handover. Even if the patient is unconscious on ventilator, it is happening right at the bedside. If I tell Rafia the patient is on, volume control mode, Rafia is already standing beside the ventilator checking. Is it volume control? How much PEEP is there? So she's double checking everything. For me, that was the safest, double check, because I know one more nurse is going to check everything with me. In case I missed something, Rafia is going to catch. So for us, that was the safety net at the time of shift handover. Every single page is, going through. We look at the patient, we look at the ID band together, we turn the patient, we look at the skin. And believe me, this is my affirmation. I can give you guarantee that if you do this diligently, you can protect your patient to the fullest and also protect yourself. Why to get into trouble? By forgetting something, by missing something and creating maybe near miss or a harm for the patient. Maybe he'll stay for 2 more days. Because I've got lots and lots of stories where one message was given like this, it was understood like Chinese whisper, and something else was happened the next day. All these things can happen because the ultrasound was scheduled to be done and the patient needed to have, full bladder. So morning shift came, patient said, I want to go to washroom. So during the handover, the night nurse forgot to mention the patient is fasting, needs full bladder for ultrasound. So the patient went to the toilet and he passed urine. And then patient went to the ultrasound. From there, I get a call, ki, ma'am, patient sent with empty bladder. So when we try to find out, a patient, when we asked the patient, did the nurse tell you in the night? Said, patient told, the nurse did tell, but I forgot because my bladder was so full. I could only think of peeing. So these are all the things, that one can remember. So I wish we had more time, but then we need to stick to our time. So it is 8:12 now. Thank you so much for being here. We have 90 plus people here. Thank you so much. And we will meet you all again on 27th of June on central line associated bloodstream infection, another very important patient safety aspect, and also a quality indicator under hospital acquired infection. So that is going to be dealt with, Lata and Ishita. So we will see you again on 27th at 7 p.m. and we are planning to give attendance certificate to those who come join the session and who give us the feedback. I am noticing a small behavior new that I have seen. I don't know whether it is because we are giving certificate. People are logging in at 7:45, 7:50, new names, and now they will also take the certificate. So we would really love all of you to come on time, listen, learn, and then take the certificate. Learn at least one thing. Let's be, honest to ourselves. So with that little request, once again, Dr. Rosaline and Ms. Rafia, thank you so much for taking us through this vast topic very quickly, and see you all on 27th. Yeah. Take care and bye-bye.
Thank you. Thank you all. Thank you, ma'am, for the
Okay.
opportunity.
Thank you,
Okay.
ma'am.
Bye-bye.
Thank you, ma'am.
Bye. Bye. Thank you.
Bye.